A new systematic review on manipulation and chronic low back pain. A recent publication once again takes on the task of gathering and comparing randomized controlled trials regarding the value of manipulation in the management of chronic low back pain in a systematic review and partial meta-analysis. For acute low back pain, the evidence is far clearer, both in the British Medical Journal and in the Journal of the American Medical Association. Recent reports concluded that among patients with acute low back pain, spinal manipulative therapy was associated with modest improvements in pain and function at up to 6 weeks, with transient minor musculoskeletal harms. But the evidence for chronic low back pain has been equivocal, including 2 Cochrane reviews published in 2004 and then an update in 2011. They were not encouraging. These reviews by Rubinstein et al. Concluded, quote, high-quality evidence suggests that there is no clinically relevant difference between SMT and other interventions for reducing pain and improving function in patients with chronic low back pain, unquote. So some important facts. The lifetime prevalence of low back pain in the U.S. may be as high as 84%, but more importantly, the prevalence of chronic low back pain is about 23%. That's millions of individuals, and it's disabling in 11 to 12%. So clearly this is an important health issue in need of effective treatment. Let's look at how this review was conducted and what the results indicate. The title of the publication is Manipulation and Mobilization for Treating Chronic Low Back Pain, a systematic review and meta-analysis published in the Spine Journal in 2018. This study is part of a larger project involving the neck, with a focus here on the low back. This was funded by the National Center for Complementary and Integrative Medicine. The purpose was to, quote, disentangle inconsistencies by evaluating the research according to different symptom durations across the spectrum of chronicity, the variations in treatment techniques, variations in comparators, and the impact on important patient-reported outcomes, unquote. The goal was, quote, to better understand the effectiveness of mobilization and manipulation for chronic, nonspecific low back pain as compared and reported in randomized controlled trials since 2000, unquote. In fact, the studies included were published between 2000 and 2014. However, interestingly, no studies meeting eligibility criteria were found between 2015 and 2017. The eligibility criteria and design were studies with participants experiencing chronic and nonspecific low back pain, studies in which an intervention consisted of either manipulation, labeled as thrust, mobilization, labeled as non-thrust, or a multimodal integrative practice including manipulation or mobilization components, labeled as a multimodal program. Also studies in which manipulation or mobilization were compared with a sham treatment, no treatment, or other active therapies such as exercise physiotherapy or physical therapy. RCTs involving adults age 18 years or older, and the study had to have at least one pain outcome, measuring a reduction in pain intensity or severity such as the visual analog scale or numeric rating scale, and disability rated by related sections of the Roland-Morris, Oswestry, or the SF-36. Of the 25 unimodal studies, 60% were identified as thrust interventions, 28% were non-thrust interventions, and 12% used a combination of both. The total number of participants across the 51 unique studies was 8,748, ranging from 19 to 1,334 participants in each study. The average age of participants was 42 years. So before we continue to the results, let's not assume that everyone understands research terminology. Let's define first systematic review and meta-analysis, and then standardized mean differences and adjusted mean differences. Systematic reviews look at qualified randomized controlled trials and sometimes other studies as a group to determine if there are consistent findings or results. A meta-analysis is a special type of analysis in a systematic review where sometimes the results can be pooled into an aggregate number reflective of all the study's results. When studies are combined in a systematic review, often the outcome measures used are different across studies. To be able to combine them, they must be standardized to one measure, allowing a standardized mean difference. Weighted mean differences mean that those studies with the most precision are given more weight in the final aggregated mean difference. We'll define precision in a moment. Now, what is important here is to realize that in the process of standardization, the actual outcome measure is eliminated. So, for example, if it is a visual analog scale, the standardized mean difference number is not a difference in the VAS. This new statistical mean difference is its own category with levels of threshold indicating effect sizes that are small, moderate, or large. But again, this is an effect size, not a difference in, for example, pain levels. We'll look at this in a moment. In the current review, a meta-analysis of the standardized mean difference was performed. Pooled effect sizes for pain and disability outcomes were translated into the visual analog scale 0 to 100 using a standard deviation of 25 points and the Roland Morris Disability Questionnaire using a standard deviation of 6 points respectively for clinical interpretation. In other words, how much of a change in these measures would be needed for the change to be discernible by the patient as improvement. There were 64 RCT publications found that met the criteria. There were 32 reports, including 25 unique studies labeled as non-specific chronic low back pain unimodal studies. These were thrust or non-thrust. And 32 reports, including 26 unique studies that were multimodal studies, in other words, programs including thrust or non-thrust with, for example, exercise or advice. Given the need to pool the results statistically, it was important that there were some statistical commonalities that needed to be met. As a result, many studies were excluded because they were too heterogeneous. These were studies comparing thrust or non-thrust intervention with a sham or no treatment control, dose studies that involved how frequently patients were treated, and multimodal studies that included other approaches combined with manipulation or mobilization. So what was left? What was included in the pooled analysis were studies that involved thrust and non-thrust interventions compared with another active therapy, for example, exercise or physical therapy, and if the treatment was over multiple sessions and post-treatment assessment was closest to 1 month across outcomes of pain reduction, disability, and health-related quality of life. Only 9 trials were included in the meta-analysis meeting the criteria. As we review the results, let's keep in mind 2 measures of value, which can occur together or separately. That is, are the results statistically significant and/or clinically significant? The pooled standardized mean difference across all studies for pain showed a statistically significant larger reduction in pain from thrust or non-thrust interventions compared with an active comparator. The SMD was a negative 0.28. Statistical subgroup analysis showed that when compared with active therapies, the data favor thrust interventions for patients with chronic low back pain with an SMD equal to negative 0.43. It's important to note, though, that among 5 trials, non-thrust interventions compared with other active comparators showed a statistically significant reduction in pain, but not as much as thrust interventions with an SMD of negative 0.20. Let's take this data and make it visually easier to grasp. This is done by a graph called a forest plot, because it brings all the studies together onto one graphic and demonstrates their means and their confidence intervals. Here's an example. The center dot is the mean, and the line demonstrates the range of values within which the true value rests. This is called the confidence interval. General rules of thumb: if the confidence interval is wide, long horizontally, it may indicate a study that is too small to detect changes, and if the line crosses 0, it indicates a questionable group of results, in essence showing evidence of effect on both sides. Let's look at this hypothetical forest plot demonstrating 3 studies. Note that this first one is deep into the territory of favoring manipulation. whereas the second one is closer to the no difference line of 0. And the third one, which actually crosses the line so that the range of values indicates favoring manipulation, but also favors other therapies. The next step, numeracy. How do we take these numbers and assign them terms that denote degree of change or effect? In general, a standardized mean difference indicates a small effect, a moderate effect, and a large effect size difference, and the reverse when determining a reduction in an outcome. We would expect negative numbers when, for example, pain or disability are decreased. These effect sizes are one measure of clinical significance. In other words, when the effect size is moderate or large, it likely makes a difference to the patient. So now we can see on this forest plot the results of this current review. The reduction in pain from thrust or non-thrust interventions created a standardized mean difference of negative 0.28. The subgroup data for thrust created a SMD of negative 0.43, and the subgroup data for non-thrust created a standardized mean difference of negative 0.2. Note that combined, it barely reaches a moderate effect. With thrust only, this becomes stronger at negative 0.43, but the confidence interval goes all the way to 0, which starts to question the precision, given 0 indicates no difference. And finally, with non-thrust, you can see it just touches on a moderate effect. Translated into a reduction in visual analog scale, for thrust interventions, this equated to 10.75 points larger on a 0 to 100 millimeter scale than its comparators, a moderate effect. Non-thrust interventions equated to a 5-point reduction on a 0 to 100 millimeter scale compared with other active comparators, a small effect. But wait, what happened over 3 to 6 month follow-ups? Well, thrust interventions compared with other active comparators trended toward an increasing effect over time at 3 months follow-up with an SMD of negative 0.68 and at 6 month follow-up with an SMD of negative 0.72, approaching a large effect size. But for non-thrust interventions at 3 and 6 month follow-up, there were no significant changes from post-treatment. And now to disability. The pooled standardized mean difference across all studies for disability showed a statistically significant larger reduction in disability from thrust or non-thrust interventions compared with an active comparator, equaling a standardized mean difference of negative 0.33. Subgroup analysis showed a statistically significant larger effect in favor of thrust compared with other active comparators, equaling a standardized mean difference of negative 0.86. This reaches the level of a large effect size. However, non-thrust interventions, when compared with other active comparators, did not show a statistically significant reduction in disability after treatment. Note the p-value. So how does this translate into the Rowland-Morris Disability Questionnaire? Reduction in disability by thrust interventions equates to a 5.16 reduction on a 0 to 24 millimeter scale than its comparators, a large effect size. Non-thrust interventions equates to a 0.6 point reduction, no real effect. So let's summarize. A small to moderate effect was found in favor of manipulation for patients with chronic low back pain with pain duration of at least 3 months or more. This effect seems to increase to a moderate effect over time at 3 and 6 month follow-up for reducing pain compared with other active comparators. Manipulation was also shown to reduce disability, demonstrating a large effect size. For mobilization compared with active comparators for chronic low back pain, the majority of several large studies did not show statistically significant differences in favor of mobilization. Well, given systematic reviews and meta-analysis are considered the pinnacle of scientific studies, although it may not directly affect the clinician and their everyday practice approach, it carries much weight for decisions made by larger groups in their clinical guidelines and the choices given to patients by managed care and other payer groups.